Just a quickie because I've got exactly 10 minutes until my EVA is done. Question keeps popping up, what should we use for fungal toenails? The answer is the same as all of the what should we use ones, which is it depends on everything that's going on. There is no right answer. If you find somebody who gives a singular answer to the question of how do we treat fungal toenails, they are doing it wrong and their job could be done by a web page. So you can basically divide it up into things from considerations from the smallest to the biggest, and that is smallest to the biggest in terms of size, not in terms of importance. For in terms of importance, it's impossible to break them up. So at the very smallest size, you have the micro level, you have the nature of the infection. Obviously, there's lots of different organisms. There's the dermatophytes, there's the yeasts, there's the molds, and lots of different antifungal agents which work differently on different things. If what you've got is, for example, a yeast, you would be better off probably using an azole, something like comalitrazole. If you've got a dermatophyte, you are probably better off using an aphene. So first of all, there is the question of what infection it is. Now, there's a lot of overlap between these. Terbinafine will have an effect on yeasts. Clomitrazole is a broad spectrum, but it is helpful if you can have some idea clinically. Then you've got the location of the infection. So, location. And this will usually be one of a few things. It could be superficial white onychomycosis. That's the sort of white powdery stuff you get on the top of the nail. Not to be confused with keratin degranulation, which is something that you tend to get after using a lot of nail varnish. It could be distal subungual onychomycosis, and that will be when, if that's the nail, there's the toe. The distal subungual will be that sort of section, or that sort of section, or something like that. Somewhere where it's not actually infected the matrix. Then you've got the proximal subungual, which is where it's back there in the area that it's growing from. And of course, which one of those it is will impact on how you decide to treat it, because they will all be different and will have different treatments. Then moving on from that, the next biggest unit is the nail itself. What is the nature of the nail in which the fungal infection is thriving? An awful lot of fungal toenails are not fungal toenails. It's a very overdiagnosed thing. So it might well be that you're dealing with a thickened toenail, an OX toenail, but because they can be superficially similar or hard to tell, you might be treating it as an OM, onychomycotic nail. Is the nail being made fragile? Is it sort of where it's growing through there causing fault lines that are causing problems, or is it just a little bit of discoloration under the end? That's an important consideration. The next important bit on from there is the skin, and by this I mean the skin directly surrounding. So if you take sort of a couple of inches around the nail, because this is almost certainly where the infection has come from. Nail infection gets under nails usually one of two ways. If there's your nail fold, there's your toe, there's your toenail. There is a seal there, the hyponychium, and there is a seal there, the eponychium, otherwise known as a cuticle. And usually what will happen is either one or both of these will be breached, and all the little fungal elements which are on the skin here will work their way either under there for your distal, or under there for your proximal, or just chilling out on the top for the superficial. If you do not address the level of fungus in the skin, then your treatment is doomed to failure regardless. It would be a bit like trying to brush your teeth while you're eating a Mars bar. You have to treat the skin surrounding it as well, otherwise it will just immediately reinfect. The other element there is that, of course, if the skin around the nail is very, very fragile or inflamed, that may affect your choice of treatment. The next level, you could say, is the foot. And by this we mean things like the vascular supply to the foot. Is it at risk? Is it a foot that is doing a lot of work? What's the environment like? Is it hot and sweaty? Is it being held inside a work boot, a steel toe cap boot all day? Or is it walking around barefoot all day? The broader context of what is going on there is important. Particularly in terms of the dilemma as to whether to use a cream or a gel or a what's the other one? A liquid. The broader context, the nature of the foot around it, is going to impact your decision. And last, but by no means least, if anything, probably most, is the patient. As I say, this is only last because I'm working from smallest to biggest size-wise. What are the patient's expectations of treatment? What does the patient actually want to get out of this? Because that will vary and that will inform your treatment plan. If there is pain, it might be that the patient just wants to be gotten out of pain, in which case just reducing the nail with a burr could be sufficient. That would meet your patient's expectations. If it's cosmetics and the nail is already coccyx, thickened or dystrophic, then getting rid of the fungal infection isn't actually going to make it look any better. So you'll need to be thinking down a different line. If the reason is that they are concerned about the risk of it, if it's getting all sort of friable there and it's actually causing a risk of ulceration or crumbling or ingrowing or something like that, that again is a different thing. So in order to actually form a treatment plan, we have to have some idea of what the patient actually wants to get out of the treatment plan. That is probably one of the first things that we need to find out in terms of the shape of the assessment. So obviously I've not gone into how these things individually affect the treatment plan, because that would be an hour's worth of proper lecture from somebody that knows it a lot better than I am. I'm just trying to give you an idea of some of the considerations which will affect how your sliders move, how you decide what treatments to use. So start with the nature of the infection, then look at where the infection is happening, then consider the nail in which the infection is happening, the skin around the nail that the infection is happening in, the foot upon which the nail is located, and the patient's expectations, priorities, what they can actually cope with treatment-wise, what they are willing to cope with or want to cope with treatment-wise. And all of those together inform your treatment plan. There are many different ways to treat a fungal toenail. All of them have merit, from doing nothing at all to combination therapy of oral terbinafine and topical terbinafine. But to decide which one, these are the things you need to be thinking about.